at Cohen Children's Northwell Health, and tonight, your moderator.
Hi, everybody. My name is Vera Foyer, and I'm the director of our school-based mental health programs at Northwell Health. And I want to welcome all our partnering districts and their families and school communities joining us for what is the first of a series for community education this year. And even though this is not a mental health topic, just as important and relevant right now. And I thank you for my colleagues from pediatrics for joining us today and sharing their expertise with you all. Gina Marie?
Great. We have an exciting event planned for tonight to give you some updates on COVID and vaccines. So allow me to introduce our panelists. We have Dr. David Fagan joining us tonight. He is the Vice Chairman in Pediatrics and a practicing pediatrician in Massapequa. Welcome, Dr. Fagan.
Thank you, Gina Marie, and thank you, everybody, for taking some time out of your evening tonight to be with us. I hope you find what we have to present useful and helpful.
Thank you. And Dr. Mandeep Kain. She's a pediatric infectious disease specialist at Cohen's. Welcome, Dr. Kain.
Thank you so much. Excited to be here.
Okay. So just a little bit of housekeeping for tonight. We have over 800 participants, which we're very excited about. I want to thank you all for sending in your question. We got, I think, about over 300 questions ahead of time, so that helped prepare our presentation. I am going to let each presenter speak about their area of expertise, and then at the end, we'll do a panel discussion to address any questions we haven't already. And you have the option of chatting in an additional question. I know there's probably a ton of questions about vaccine administration, and as you can imagine, it's been challenging for all, and we continue to follow all state regulations in that area. So what we've done tonight is in the chat, we're providing all the information we have about getting vaccines, so we're not able to go too much into that tonight, but we will certainly kick it off with Dr. Fagan and giving us updates on COVID.
Great, thank you, Gina Marie. And I'm going to share my screen with everyone, and hopefully you can see it. Okay, so I think we're good.
You're good.
All right, so I'm going to give you everybody a kind of a potpourri, a number of different topics related to COVID. And I just want to start out with reminding everybody of what the symptoms of COVID are. And this list comes from the CDC. And keep in mind that these symptoms are very, very similar to symptoms we see with many of our common wintertime illnesses, not only influenza, but any other number of different viruses that cause a variety of illnesses in our children and our pediatric population throughout the winter. And as I have in highlighted there, most symptoms occur anywhere between 2 and 14 days after being exposed to COVID virus. And that's why we have a quarantine period of 14 days. So this is to give everybody a sense of kind of where we were and where we are now. And this is data from the New York State website, and we're looking at data specific to Long Island, therefore Nassau and Suffolk counties. And on the left side of this graph, we go back to March, and on the right side, we really go right up to the present. This data is through Sunday. The orange line shows you the percent of tests that were for COVID that were positive. And you can see early on in April, over 50% of tests for COVID were positive. So 1 out of every 2 COVID tests were coming back positive. And then as we got into the summer months, that number dropped. And that number was really hovering between 0 and 1% throughout the summer and into the early fall. And then as we get to the right, we see, if you go like the middle of November, that uptick starting there, continuing after Thanksgiving, continuing through the rest of the holidays. And we are hopeful now that that orange line is trending down and it will continue to trend down. The other thing I want to point out on this graph are the blue bars. And the blue bars are the total number of patients that that were tested. And you can see as time has gone on, we've just done more and more testing in the United States. And the orange or yellow bars at the bottom are the number of positive tests. So we're doing a tremendous number of tests. Some days in New York State, there are over 200,000 tests that are done. Now, how does COVID affect the pediatric population? Since that's what we are, a children's hospital, and that's, I'm a pediatrician. Dr. Kainth is a pediatric infectious disease expert. So this is data that's put out by the Children's Hospital Association, as well as the American Academy of Pediatrics. And if you take all COVID cases in the US, about 12.7% of these cases are positive. And this is data that's through January 21st. This number has slowly increased. If we went back to the early fall, it was around 9 or 10%. And now it's up to almost 13%. So about 13% of all COVID cases in the US are occurring in children. And this is the most complete data set that we have for children, although it does not include every state. Interestingly enough, New York State doesn't report this data by age. New York City does. And that's just an interesting quirk. So this is the number of cases, again, from the Children's Hospital Association in children each week as we've gone through the pandemic. So the number of cases added each week. And you can see the most recent week, 165,000 new cases throughout the United States in children. Now the question becomes, well, how serious are these cases? And, you know, we've all heard that for the most part, COVID is a lot less serious in children. And as a general statement, that is true. If we look at this slide, through January 21st, in the United States, about 10,600 children have been hospitalized. And that's throughout the entire pandemic. And that makes it, that's about 1.8% of all hospitalizations for COVID. So very, very few children as a percentage of total hospitalizations are in children, are in the pediatric population. So I want to switch gears a little bit and talk about testing. We get, I can't even begin to tell you how many questions on a daily basis about testing. What are the kinds of tests? Is there an advantage to doing the quick tests? So I want to take everybody through this and hopefully clear up some of the confusion. So if you have symptoms that are consistent with COVID, you want to test right away, fairly quickly. And then a rapid test is something that can be employed, as well as the nasal swab, which is the what are known as PCR tests. And timely testing is important in symptomatic patients, especially if they're in school settings, work settings, because the need to do contact tracing and home quarantine as soon as possible. Now, delayed testing, and this is really very important because this is what we get calls about every day in our offices. So let's say your child had close contact with someone who was infected with COVID, but your child has no symptoms. You don't want to rush to test. You want to wait at least 4 days, according to the CDC, according to the American Academy of Pediatrics, before you test. Because as I said earlier, symptoms can take 2 to 14 days following exposure to manifest themselves. So we really don't advise testing, sooner than that. And for asymptomatic patients, a rapid test is probably not the way to go, because it's very likely that you can have a false positive rate without any symptoms with a rapid test. The rate actually, the rate can be, the accuracy can drop to as low as 41%. Now, are there situations where we shouldn't do any testing? So let's say your child had contact with someone and that someone came in contact with someone who's positive. Should you have your child tested? Well, if that, so that's what we call an indirect exposure. And because your child did not have direct contact with the infected person, we would not recommend testing unless, of course, that person your child did have contact with became positive or your child began to have symptoms. So now what do you do about the patient or the child who had COVID and then came in contact again with someone? And it's not recommended for asymptomatic patients who previously tested positive to do any more testing for 3 months, because you have genetic material from the virus that still can be captured and picked up by the PCR tests. So we don't recommend, and the New York State guidelines and the Nassau County Department of Health all advise against requiring a negative test, say to return to school or to return to work or whatever after testing positive, because again, you can have evidence of the genetic material of the virus that stays in the nasopharynx. In the interest of time, I'm skipping over these next 2 slides, and I want to talk a little bit about another question we get asked all the time. Is it safe for my child to be in school? I'm deciding if I should send my child into school or if I should keep my child at home and learn virtually. And what we've learned over the last really 4 months since September is that schools are really the safest place for children to be. It's a structured environment. There are rigorous protocols in place in terms of mask wearing, social distancing, hand washing, hand sanitizing, the use of plexiglass barriers, and the redundancy of all these safety measures has really made schools a very, very safe place to be. This is a snapshot of an article that appeared in Newsday shortly a few weeks ago, December 20th. And at that point, so we're talking about a month ago, there were about 5,500 students on Long Island aged 5 to 17 who had tested positive, and about 2,200 staff members. And if you compare that positivity rate in the schools compared to the community at large, much, much lower. So schools, very, very, very safe place to be. We haven't seen transmission spreading through schools. And I'm going to quote from the article: the Suffolk County Department of Health is aware of only 7 cases that originated in a school, and all of those were among a group of teachers who held a birthday party in a small faculty room. In Nassau County, health officials said they have not identified any cases that were transmitted within schools. So again, bottom line, schools are a very safe place to be. Now, this is really new information. This is from actually today's Newsday. Last Friday, New York State issued new guidance on winter sports. And basically what the state said, they were clearing the way for all high school and recreational sports leagues to begin as soon as February 1st. And the guidance from the state is leaving it up to local health departments to first approve competitive play. So Nassau County Department of Health has said that they will approve it. Suffolk County is a step ahead. They've approved it, and Suffolk County has already published their guidelines, which will include weekly testing of athletes, temperature checks, attendance logs for practices and games, masks and social distancing when not competing. And this is most important for what are called the high-risk sports, which you can see here. So those include wrestling, football, ice hockey, rugby, basketball, contact lacrosse. So these are the sports where there's the least ability to maintain physical distance and the least ability to avoid touching of shared equipment and clean and disinfect equipment between uses. So we are very excited for the return of high school sports beginning in February. The other piece of the guidance that everybody should know is, although the health departments for each of the counties have approved the return for sports, it is being left up to each individual school district as to whether they will participate in these high-risk sports. For the lower risk sports, that's not an issue. I'm in the home stretch. I have really just 2 more slides I want to share with you. And I want to talk about influenza very, very quickly. These are symptoms that are common to both flu and COVID. And then you can see symptoms that are more common in COVID would be the loss of taste or smell. Now, each week, New York State puts out a flu, basically, report card. And what I want to draw your attention to on this slide, and I apologize for it not being completely clear, is that red line on the bottom. So this graph, we're looking at positive flu cases that are reported to the New York State lab by flu season. The green line is last year's flu season. And if you just follow that green line out to March of last year, you can see it just drops right off. When we went into lockdown, the flu season ended. The brown line is 2018, 2019, which was not as severe a flu season, but you can see how much longer the flu season usually goes into the spring compared to last year. But now look at this year, the 2021 in red. We've seen nothing. And that's because more people have gotten their flu vaccines this year. People are practicing social distancing. People are wearing masks, and people are practicing good hand hygiene. And why am I talking about this? Because if we had a terrible flu season and we had a rush of patients going to our emergency departments and our hospitals with influenza at the same time that we've seen this uptick in COVID in November, December, and January, we would be in a much, much worse situation. So this is my last slide, and I just want to show you. These are hospitalized patients with the flu. And again, look at that red line, which is this year's flu season. Hospitalizations have been next to nothing. We learned today that within our hospital, Cohen's Children's Medical Center, to this point in the flu season, we have not admitted 1 child for influenza. So I want to thank everybody for their attention, and I will at this point turn it back to Gina Marie. Thank you. And I stop sharing my screen.
Thank you, Dr. Fagan. That was very informative. Dr. Kanth, we will turn it over to you now. Please give us an update on the vaccines and this new strain.
Sure, I'm happy to do that. I'm going to briefly go through a few of our fun facts about vaccines and viruses. We'll talk a little bit about some of the myths of the COVID-19 vaccine. We'll also touch on vaccine safety and mutations, and that will be a little bit of a shift when we talk about that. So just some fun facts. The word vaccine comes from the Latin word vacca, I hope I'm saying that right, meaning cow. And vaccines were actually initially first discovered back in 1796, so many hundreds of years ago, by Edward Jenner. What he did was he inoculated an 8-year-old named James Phipps with the matter from a cowpox sore. So there was something called cowpox that milkmaids would get. And they found a sore on the hand of a milkmaid, took that matter and gave it to this child. And it turns out that, and Edward Jenner didn't know that, but he was creating an immune response. And that's what a vaccine is. It's a product that stimulates an immune response to produce antibodies or immunity to a specific disease, and it protects you from that disease. So just a little mental quiz for all of you. So by the time a baby is about a year old, how many diseases do you think they are protected against by vaccines? Do you think it's 8 or 10, 14 to 15, or about 17 to 20? So it's actually about 14 to 15. That's quite a lot of vaccine preventable diseases we've been able to, keep our kids healthy and out of the hospitals, and it's been a great triumph. And these are some of the vaccines that we use, and the infections that we are protecting against are things like hepatitis B, DTaP, which is diphtheria, tetanus, pertussis, Hib, which is for Haemophilus influenza, which can cause all sorts of things such as meningitis and ear infections, as well as what Prevnar protects you against is from strep pneumoniae, which can cause the same things. IPV, that can cause polio, which is now eradicated pretty much globally. MMR, which measles, mumps, and rubella, that vaccine's been around for 50 years. Varicella, which is for chickenpox. Rotavirus, which is the most common globally known cause for dehydration and can cause severe illness in young babies. And of course, that influenza vaccine and BCG, which prevents tuberculosis. So by 1 year of age, babies can get from 20 to 23 shots. And that's all to protect them from all these diseases that we used to see, but we don't see as much anymore. So here are some fun facts about viruses. You're constantly exposed to viruses in the air you breathe and the things you touch, the water you drink. And most of these viruses we have antibodies to, which we have protection. And that means that those antibodies can mark that virus as an invader. So your white cells, those good healthy immune cells, can engulf them and destroy them. And so what's important to know about COVID-19, which is the disease, it's actually caused by a virus that has a different name called SARS-CoV-2. So how does SARS-CoV-2 work? So it's a virus that has this crown of spikes, as you see here. And what it does is one of those little spikes on the crown can attach to something called an ACE2 receptor. And this is your human cells. So this is like representing one of the cells in your body. And to get into your human cell, it needs to bind and then come in and becomes integrated into this part of your cell machinery. So it's really your own cell that makes more virus particles and then releases those particles, and it's what makes you sick. So the important part here is this spike protein, and to keep in mind that this is part of the reason why we are interested in the science of how this works, because if we can prevent entry into one of your human cells, we can prevent the virus from reproducing and making you sick. So when a vaccine is given, it actually contains something called an antigen. An antigen is a protein, and these proteins are picked up by your immune cells. And there's so many different types of immune cells you can see here. On the top layer here, there are these B and T cells, and then these other T cells on the bottom layer. The B cells are making your antibodies, and that's what helps bind those vaccine proteins or antigens, and then helps get rid of them from your body. And then these T cells are the types of immune cells that can actually try to kill the human cells that have active virus in them. So even though you might feel like that might be a bad thing, it's actually a good thing, because you don't want to keep those infected cells with a virus in there, because it'll just keep making more virus and make you ill. So what are the types of vaccines that are around? So you'll hear about MMR and varicella. These are live vaccines where they use live virus, but they actually weaken that virus. It's called attenuated in order to create an immune response. And then there's killed vaccines. So polio is an injection, and Hep A is an injection that can just be a killed virus that's being given to you to produce that immune response. And then there's inactivated toxins. So some bacteria or viruses create toxins, and those toxins are made a little bit weaker, and they're then given as a vaccine to protect you from bacteria. And then the final one is a conjugate vaccine, which is really using part of the virus or bacteria and an additional protein combined together to create that vaccine and to give your body an immune response. So how does the COVID vaccine work? And how is it different from those other vaccines? So there are actually 3 different types of COVID vaccines that have been under study. And the first one is basically where you take that crown spike that we saw that sits on the outside of the virus, and it's purified, and it's then injected into your body and creates that antibody response. And that's that antigen. here we see this spike protein put into another weakened virus, and that tricks the body into saying, oh, I need to make more of this virus and make more of this protein. But then your body detects that protein, which is not going to make you sick, right? Just that little protein doesn't make you sick. It's the whole virus that makes you sick. Will detect that little protein and start making antibodies. And then the last type is the one that you've heard all about and know all about. This is the mRNA vaccine. And mRNA is found in that part of your cell where the virus uses your machinery to reproduce itself. And mRNA codes for that protein. So instead of just giving you a straight antigen or an antigen in a virus, it gives the code for that protein. And it's purified and injected. And then your body says, I'm going to make this protein because it knows what mRNA is. It has every single cell in your body has mRNA, and it uses it every day, all the time. And it says, I'm going to just make this protein. And your body says, wait, I don't know what that protein is. Let me make some antibodies because I don't recognize it. And I'm going to make some antibodies to protect myself against it. So the two vaccines that are available currently in the United States are the Pfizer and the Moderna vaccines. And both of them are 2 doses. Pfizer is done 21, the second dose is done 21 days later, and for Moderna, it's 28 days later. Both have similar efficacy, and I'll go into this in a little more detail, but that means that 95% of the time, it's going to prevent you from having symptoms of COVID that we just learned about from Dr. Fagan. And 90% of the time for Pfizer and 100% of the time for Moderna, you'll be protected against severe disease. And this is, again, related to being hospitalized, being very ill with COVID. And so we can use the Pfizer vaccine for kids 16 years and older, and for Moderna, 18 years and older. There are really no serious adverse effects for either vaccine, but they are known to be what we call reactogenic. And reactogenic means that it just creates a very good immune response. And that second dose seems to give a little bit more of those extra common side effects, some headache, fatigue, sometimes some lymph node swelling for the Moderna, those gland swelling, and really, other common vaccine side effects. So this is to explain vaccine efficacy, and I want you to divide this table in half down the line in the middle, one half about Pfizer and one half about Moderna. And so we'll see here that out of the many, many tens of thousands of people who volunteered for the Pfizer vaccine trial, half of them received vaccine and half of them received a placebo, meaning, or a division received a placebo, meaning when you don't get any vaccine. And what we saw was that those who had gotten vaccine, those 9 all had symptoms, compared to 169 who did not get vaccine who had symptoms. And so when you compare this to Moderna vaccine, you see here that the vaccine, again, had only 14 individuals who had symptoms with the vaccine, compared to 185 who did not get the vaccine. So that's where these efficacy numbers come from. And then the next step was to decide if this is also helpful for a severe infection. So will you end up in the hospital needing oxygen support, needing supportive help to get better? And it also showed that we could see that the vaccine had a much lower number of people who had severe infection, 1 compared to 9, and 100% effective, 0 compared to 30 from Moderna. So we saw this across the board, no matter what age you were, what sex or race you were, or if you had other comorbidities, we call them, or high risk factors like cardiac disease or diabetes or lung disease. So I'm only going to briefly mention these other viruses. I just want to mention that adenovirus vaccines you might be hearing about soon. This top one here has already been approved in the UK. It's a 2-dose vaccine, but the interesting part that, as we saw before, that vaccines reduce how ill you can become with the virus, and how many symptoms you can have with the virus. But this actually can maybe even reduce the ability to carry the virus in your nose and mouth, and in your secretion. So that might actually be very helpful to helping get over this pandemic. And this is an interesting vaccine that's produced by Johnson & Johnson, the second one on the that actually is a single dose. So that also will make us to be able to get vaccines out to people. And so, you know, a lot of people have a lot of questions about vaccines in general and about this mRNA vaccine. And one common one has been, you know, mRNA vaccines, they must contain tissue or cells from aborted fetuses. I saw this, I know about it, and it's actually a myth. That is not true. So vaccines do not contain any tissue or cells from aborted fetuses. In the laboratory, there are clones of tissue that was harvested many, many decades ago that are clones of those cells that are not actual tissue from aborted fetuses that are used in development of many technologies and vaccines, but the vaccine itself does not contain any tissue or cells from aborted fetuses. What it does contain are cell-free, human or animal product-free, preservative-free messenger RNA, which is synthetic, meaning it's chemically produced, or it's mRNA. There are all these other contents, and some of them you might recognize as parts of other medications you've taken, like polyethylene glycol is a stool softener. And so you can actually find this very easily, this information. But as you see here, a lot of these products are already used in many food products even, and other medications that you take regularly, and other things that you produce normally in your body. So another myth or fact. So COVID-19 mRNA vaccines can alter your genetic material, and that is a myth. So we saw that little picture earlier about how the virus uses your cell's machinery, and that's in the outside, like liquid part of your cell. It's called a cytoplasm. But your genetic material is contained in the middle part of your cell, which is the nucleus. And that means that the stuff that comes out of your nucleus or into your nucleus is actually contained in a barrier. The mRNA cannot pass that barrier. It doesn't have the ability to do that. And so this way, there's no worry or concern that you might need to have for vaccines or with mRNA causing a problem. And this is just an example of that, how you get a vaccine, the vaccine protein travels to your lymph nodes, and that's where all your immune cells hang out, and that's where your mRNA enters the cell. Again, this is the nucleus of the cell in that dark gray area, and then the outside of the cell is the cytoplasm. So your mRNA is actually, from the vaccine, is used here, and you use mRNA all the time, every day, to make this protein, and it cannot enter here. It's not, it's a very big molecule, and it cannot pass through. And then you're able to get these immune cells to come and say, okay, now I know what this protein looks like, and I can protect myself against it in the future. So we know that the mRNA can't enter the nucleus, and then basically has been able, your body destroys it in a few days, and by then your antibody response has already happened. So a myth or a fact, mRNA vaccines are brand new technology, only discovered in the last year, and that is a myth. We have heard a lot about vaccines that are coming out very quickly, but in fact, this has taken quite a long year to produce. As soon as we knew how the virus was coded back in the winter, when that was last winter, people started working on this technology right away. And actually, it's been already produced for a previous virus that's related to SARS-CoV-2, which is just SARS, which you may have heard about. And about a decade ago, folks were interested in creating an mRNA vaccine to that virus. So we actually had already been working on a related virus vaccine with mRNA for quite a long time. And there was no shortcuts to those studies. So they had done all of the studies that all of the check boxes that you need to do with a normal set of clinical trials. And so what is mRNA technology? It's really a synthetic form of genetic material. And mRNA vaccines take advantage of the process that human cells already use to make proteins to make an immune response. And there are always studies ongoing for other viruses and vaccines. mRNA vaccines don't contain any part of the virus. It is not a live vaccine. And it only contains that spike antigen. It codes for that spike antigen, but it doesn't contain actual part of the virus. And the mRNA does not enter the cell, the nucleus of the cell. So here is just, again, evidence. This was published actually in 2019, before we even knew about COVID, that there were at least already 3 decades of mRNA vaccine development. So some common side effects already mentioned, the common ones: fever, pain at the injection site, chills, fatigue. And again, severe adverse effects are very, very uncommon. They were comparable in these study arms to each other. So if you didn't get vaccine versus you did get vaccine, you are equally likely to have an adverse event. And none of these really events were any more common than what's seen in the general population, which is how we look for safety in a vaccine. So who should not get the vaccine? So I mentioned the components of the vaccine earlier. So if there's a severe history of a severe allergic reaction to one of those ingredients, that's someone who should not be getting the vaccine. So is one vaccine better than another? No, both vaccines are really quite highly effective, commonly have some of these, common adverse effects like headaches and fevers and muscle aches, but not really associated with serious effects. A common question, I know we've been asked about when do you get your first dose, but when you do get your first dose, you're going to be asking yourself, when do I get a second dose? And that's can be 21 days for the Pfizer, 28 days for Moderna, and there is a grace period. We can get it a little bit earlier for both of them and a little bit later as well. Is there a contraindication to second dose? Well, yes, a severe allergic reaction within hours of that first dose that requires medication. But those other more common side effects are not contraindications, so you can still get it. This is just a review of how we're allocating vaccine. And I know this is probably the most controversial slide I'm going to talk about today, but so we see here that at the end of the year, last year, that healthcare personnel, long-term care facility residents, which are about 25 million people, were prioritized. And then we saw that later on, the beginning of this year, we saw frontline workers now being prioritized, and then opening up later on to the elderly who were actually as young as 65 and older. But I need to point out these numbers to you. So this is in the number of millions of people. So just alone, this is 24 million people. Then you have another 30 million people. Then you have another 20 million people. And now with this extra layer, you have 30 million people. So if you do the math without this extra layer of people, you have about 60 million people. That's 120 million doses of vaccine that would be required to vaccinate everyone. And then here you would have another 30 million about. So that's 90 million people, 180 million doses of vaccine for just this tier. Okay, so that is a lot of vaccine to be produced. And there's manufacturing that's been going on pretty much even before we had results of the studies, because there was such a need. And I think this is where some of the concern comes from of why this was, why is there a vaccine that's not available now? Why is it so difficult to get a vaccine? And to be honest, it requires a lot of coordination. So not only do you need the technology, which we talked about, but you need the financial backing to create these vaccines. You need the supplies, all those components I mentioned. You then need a way to administer these vaccines to everyone. And it's not, and actually the amazing thing about the Pfizer vaccine was to get this vaccine stable enough that it didn't require such cold temperatures, and it can be transported easily, as well as with the Moderna vaccine. So, these are important parts of delivering vaccine. It's not just getting a shot. It's all about making sure that shot is getting to the right person and getting to the person so that the vaccine will work. If the vaccine vial is open for too long, it will not be as effective as far as we think. And so we want to make sure that we are getting enough shelf-stable vaccine to everybody who needs it. So just a quick summary about vaccine myths. It was not rushed. Researchers took no safety shortcuts, and we have large studies to show the vaccine's safe. That was, part of the trials that were done. We went out into detail about how it's impossible for it to change your DNA, and that how it is not a live virus vaccine, so it does not make you sick with the virus, and it doesn't contain any egg protein. So if you have an allergy, you shouldn't be worried about it. And for the most part, you can have mild side effects, but they all resolve within a few days, and there's no evidence at all that vaccine causes infertility. So vaccine is extremely effective in preventing COVID-19. Efficacy is consistent in all age groups. And it includes all of these folks who have also these comorbidities. There is a temporary local reaction to vaccine that's known, but the known potential benefits far outweighs the potential risk, and it will help us get a handle on this pandemic. I'm going to take a quick detour because there's been a lot of talk about mutations in the news, and I'm only going to quickly mention this so we have enough time for questions. But basically, we've been seeing back in the spring when this all happened, we saw a very small mutation in the virus in that spike protein, those receptor binding area. And now we're seeing a little bit more changes in the UK, which means that the goal of a virus is to reproduce, right? It wants to get into a person or a host and make more of itself and get to another host and get from population to population so it can do its job. And so the more transmissible a virus is, the more it will select itself out because it will want to propagate itself forward, and all the other ones who are not as good as propagating themselves will kind of die out. And we started seeing this in early September. And then later on, next month, we saw another one emerge in South Africa. And, these places are a little bit of a misnomer. I mean, they've been found in other places, the US, Zambia, now globally, and even now another variant in Brazil. So we're keeping a close eye on these variants. So far, we're not seeing as much severity changes in disease with them. But this is an interesting graphic of, since January, what exactly this lineage, we call it, or what the evolution of the virus has been. And you see the different numbers here, 19, 20, 20. And you see here, this is on the bottom where the blue arrow is the variant, the UK variant here. And you see this quick upswing in December and January of how often you're seeing these variants. And so it's very interesting how these have already changed, but that's how viruses work. They change on small levels, and that happens all the time. It's when there's a big change that we get worried. And this is really what's going to happen next. Do we worry about, say, for example, will it become more and more transmissible? Well, if we have more cases and we don't get this under control quickly with a vaccine and with masking, hand hygiene, and social distancing, then there is that chance. But the faster we can work on getting all of those under control, the faster we can avoid more mutations. So far, we're not really seeing much severe infection. There's some early reports from the UK, but I always have a disclaimer that I wish I could read every single paper and article in scientific journal that comes out every day. But as we learn more, some of the things that I say may change, but pretty much there's no evidence to date that the vaccines are not going to work and not induce an antibody response, because it's creating immunity to that spike protein on the crown of the virus. And that has many, many different proteins on it, not just one small area, small protein that can be in a mutation. And we don't really know if there's any agents such as monoclonal antibodies that can be decreased susceptibility to virus. Unclear. We'll probably need more information as that time goes on. So I just wanted to thank you and thanks to my mentors, Dr. Lori Rubin, Dr. Sujata Rajan, who I work with, who helped me out with these slides today. And these are my munchkins who I hope, like all of you, stay safe, and I hope all your children stay safe this season. Thank you so much.
Dr. Camp, thank you so much for that very informative presentation. I'm going to stay on you for a little bit and go through some of the questions that we had that were written in previous to tonight and also throughout tonight's session.
Sure.
One of the ones that comes up often is about the efficacy of having this vaccine, how long that lasts, before it's reduced, and when do you think patients will need to get reinoculated?
So the hope is that if there aren't any mutations in the virus, that because this is coding for all of that spike protein, that hopefully we won't need to re-inoculate. And it really depends on the evolution of the virus itself. And I don't have that crystal ball to tell you if it's going to mutate so much that we're going to need another vaccine. And the hope is that we won't. But at this point, we're seeing pretty good immunity. And like I also like to tell people that efficacy, what we see in a trial, is different than effectiveness. And effectiveness is what happens in a real population. And so what we know, what we'll see happen in our population, if we can see our numbers go down and our number of cases go down, that also will show that we have an effective vaccine in the future.
Okay. Another common question is, if you're vaccinated, can you still carry and pass on COVID? I know we're all waiting to see our parents again and for our little ones to hug them. And so if we get vaccinated, can we still pass on COVID?
I know. I actually just had to explain this to my colleagues yesterday. And it's an important point that I tried to make in my presentation, which was the vaccine is there to decrease the symptoms of COVID, so less likely to cough or sneeze or give that virus to someone else in that way, or to reduce the severity of your illness, so reduce how sick you can get or get hospitalized or even unfortunately die from the virus. But those studies were not what we call powered to see if, or structured to see if you are asymptomatic, meaning you don't have any symptoms from COVID and you're carrying that virus in your nose or your mouth or your droplets, that you can't still transmit that to someone else, which is why even as a healthcare worker who's vaccinated, I'm still wearing masks, I'm still social distancing, I'm still washing my hands, and I'm still using all the precautions I would normally use. And that's until we reach that herd immunity where we're able to say that there are enough people who are vaccinated in our population, in our communities, that we're not transmitting virus, or until we get data, like some of the other vaccine trials are looking at that information, and we'll get more data from the population itself to see maybe we will be able to stop transmission and as more people get vaccinated.
Thanks. There's so much that we don't know about this virus and the vaccine. But to go back to some other vaccines that we do know about, let's take the annual flu vaccine. Once we get vaccinated, that again is to prevent symptoms and getting the virus. But even in the flu vaccine, are we still able to transmit that to other people who have not been vaccinated?
So it's a good question. So it's shown to definitely reduce hospitalizations and reduce severity of disease, absolutely. But this is what we have never really done before. This is like an experiment in action where we've never really masked all the time, washed our hands so vigorously, used so much hand sanitizer that we run out at the local store. And so there are other reasons that we are not seeing influenza as much as we're seeing COVID, because COVID can be in the air. And so when we see that over time that we don't see as much influenza, it's mostly because we have been vaccinating against strains that come out. But the thing is that every year, typically a different strain becomes the more common strain, because again, the virus is just trying to survive and it's just trying to outwit us. And every year it comes out with a slightly different mutation, and we're just basically trying to figure out the best combination of vaccine variants in that or vaccine strains to various strains in the vaccine to get you to not get ill. I hope that answers that question.
Thank you. So we have 10 minutes left. So I'm going to focus some of these questions really on, I think, what's near and dear to our community tonight. The first is, I know you touched upon it on your presentation, but I'd like to ask you again, what is the recommendation for getting a vaccine if you're pregnant, if you're trying to conceive or in your fertility years, and if you're breastfeeding?
So the studies, again, were not geared towards women who were just women of childbearing age, or just women who are trying to get pregnant, or just women who are pregnant or nursing or breastfeeding. So without looking at that specific population, we can't make a standard recommendation, but we do know that this is a vaccine that is not a live virus vaccine, which might have consequences if given during pregnancy. And many, many other vaccines, such as a tetanus vaccine and flu vaccines, are given in pregnancy, and this acts just like those vaccines. So there should not be harm to an unborn child or to a nursing child because you get a vaccine. Now, the other point I'd like to make is that if you are trying to get pregnant, it is actually even probably more important for you to get your vaccine prior to conception, because you are at higher risk of having severe disease and hospitalization and symptoms of COVID while you're pregnant than when you're not pregnant. And you'd want to have those antibodies in your system when you are pregnant. That being said, it's a decision that you have to make with your doctor. I have not really heard an OBGYN tell me yet that they've ever told a family that they shouldn't get a vaccine, or a parent or a mother that they shouldn't get the vaccine, unless there's another extenuating circumstance that could be on a case-by-case basis.
Great, thank you. And I believe ACOG, the American College of Obstetrics and Gynecology, did come out with a statement. And of course, it's something you should be discussed with your own healthcare provider. However, I did want to share that one of our participants tonight is one of our maternal fetal medicine specialists, an OBGYN at North Shore University Hospital. And she really wanted to make a point to write in tonight. It's Dr. Kara Pessel, for anyone maybe who lives in her community or has been one of her patients. But she wanted to make a point. It's really important because in OBGYN and MFM, they are strongly encouraging pregnant, breastfeeding, and reproductive age women to get the vaccine. So again, if you have concerns, talk to your provider, but it is a very strong recommendation to continue. There's actually no science or evidence to believe that it has an impact on fertility. So I wanted to make sure to share that, particularly with this group tonight.
2 thumbs up, I agree.
Thank you, Dr. Pessel, for writing in as well. And then, of course, most of our participants tonight are parents. So I wanted to spend a couple of minutes on children in the vaccine. Do you know when the trials will be starting for children under 16 for the vaccine?
Yeah, so there are already trials underway for the Moderna vaccine for children who are 12 and above. And then we are hearing about other vaccine companies that are interested in creating a protocol for that younger age group. And the way this typically works with any vaccine, this is no different than for a COVID-19 vaccine than for any other vaccine, is that you start with the older age group and you work your way down. And that's also particularly for COVID-19 because we know, as Dr. Fagan pointed out, that children who are younger actually are not as high risk for severe infection that lands them in the hospital, which is what we're giving the vaccine for now. And we also have seen from the school data that we heard today from Dr. Fagan that we're not seeing as much transmission from children if you're putting into these precautions in place in the schools. So for now, we really need to get the mortality down in the United States. We have over 400,000 deaths in this country. We need to tackle that problem first and foremost, and we also need to tackle the number of hospitalizations because our healthcare system, once it gets overwhelmed, something else hits us, with another spike in number of cases, it's a detriment to our community and to our population.
Okay, so we're still a ways away of vaccinating our kids?
I think it'll be a little bit longer than all of us think. I think the data is probably going to come by faster because we don't have to go through all these other phase 1, phase 2 trials to get that information, but they still need that same amount of time after you're vaccinated to look at your antibody response. And we don't want to put any shortcuts in, right? So we still want to get good scientific information. So it definitely will be probably at least months before we get enough kids enrolled, and maybe not until, I don't even want to gander guess at how long it'll take, but it will be a little while, but it'll be months until we actually even have any data.
Okay, thank you. Dr. Fagan, I want to go back to your presentation. We did have several questions throughout. The first is, you did mention that the virus can take up to 14 days to show symptoms and could be contagious. And we all know that was the original recommendation for quarantining, but the CDC in New York State, and thus many of the school districts here on Long Island, have updated that quarantine to 10 days. Can you give us your thoughts about that and whether or not you think that's safe? You're on mute, Dr. Fagan.
I apologize to everybody. That's a great question, Gina Marie. So yeah, in December, early December, the CDC came out and said quarantine period can be lowered to 10 days for patients who are asymptomatic without doing a test, and could even be lowered to 7 days with a negative test if you were asymptomatic. There's still a risk of post-quarantine transmission. CDC estimated that with 10 days to be at about 1% and to be up to 5% post-transmission for somebody who ended quarantine at 7 days. New York State followed suit, not right away, and we were like wondering, well, what is the state doing? The CDC, came out with this in early December, and it wasn't really till after the new year that the state said, okay, yes, we are going to lower the quarantine, and then the school districts followed suit. So in my initial presentation, I did mention the 14 days, but I don't want people to get this false sense of security, because the CDC still says that symptoms can present as late as 14 days. So you still need to be vigilant. You still need to be self-aware and aware of the symptoms in your children, even if that quarantine period has ended at 10 days. So yeah, that's what it is. And we, in our pediatric practices, we follow the guidelines from the state and the CDC, but the caveat is you can't ignore signs and symptoms that may appear on day 11 or 12.
Dr. Fagan, as a parent, I think it's very hard to determine when we need to get our kids tested and when we're not. And I'm someone who has access to you and all our experts all the time. So, you keep hearing it's a cold, it's probably just a stomach virus. Are you, as a practicing pediatrician, are you seeing the common cold and stomach viruses? And what is your recommendation? At what point do we get our kids tested? Is it a runny nose? So
we're really seeing very, very little in the way of, and just in terms of numbers, volume of the common things that we would normally see in the wintertime. Coughs, colds, ear infections, stomach viruses, we're really just not seeing them. And, so how do you differentiate? How do you decide, do I test this child for COVID? Do I not? A lot of it has to do with how much COVID's in the community. So, when we were back in, September, and I showed those graphs where 1% of tests were coming back positive, and there was really very little COVID in the community, you could say, okay, this is unlikely to be COVID. You don't know for certain. But now with, the numbers being what they are, and we're hopeful that, again, from the graphs I showed, that we're on that down slope again. But I'm telling, and our pediatricians are telling patients, look, these are symptoms that are on the CDC list of symptoms of COVID, and there's enough COVID out there that we don't know, that we get the test results back typically in 2 days. And so if basically we're saying if the symptoms are on the list and your child has them, the right thing to do is test, because you won't know otherwise.
Okay, thank you. So we're at the top of the hour. I am going to ask just 2 more questions to Dr. Camp because I think that they're important questions about live virus and the vaccine. So Dr. Camp, we received a lot of questions about whether or not, what is your recommendation or the official recommendation for getting a vaccine if you've already had COVID?
So the official recommendation is that if you've recently been infected with COVID, you should not get the vaccine. But if you are convalescing and doing well, I believe the recommendation is somewhere between 10 and 14 days after you're feeling better, you can get your vaccine. So as long as you're not still ill with the virus, you can get the vaccine. Some people are saying to wait 90 days because you probably will have antibodies left over from your illness, and the vaccine may not be actually required for you right away. So it's almost like you're opening up that dose for someone else who may have not been infected and may not have antibodies, who might need that sooner rather than later. But it's a wide range. So there's really no contraindication to getting the vaccine. Like if you did get COVID and you happen to get the vaccine a month later or 2 months later, but there is theory that you have antibodies for at least 90 days. Excuse me. Now with this mutations that are happening, we don't know if you've gotten infected with the previous mutation that you're protected against the new ones. And the idea is that you should be. So that might be another reason to think about getting your vaccine.
Okay. And then another common question is, there's this fear that there's not going to be enough for the second dose. So let's say you get your first dose. I know there's a lot of things like that. I didn't get the appointment for my second dose. We're running out.
Mm-hmm.
Or maybe I get sick or I'm away. What is the time frame to get the second dose? I know that you can't get it before the 21 or the 28 days, depending on the vaccine. But what happens if it's 2 or 3 or 4 weeks after that?
So it's still fine if you get your second dose after that. So basically, it is a booster dose. You have about, I think with the Pfizer vaccine, about 50% protection after your first dose and a little bit higher for Moderna. And then the second dose should be available to you. And actually, what I am hearing is this concern that if you have an appointment, you're not able to get another appointment. So the place that gave you the first vaccine should be your go-to place for your second dose. And they should have set that aside for you. The problem with supply chain right now is not necessarily for those second doses. The supply chain is because we want to keep those second doses for those who have already gotten it, and we are not getting enough first doses, quote unquote, to basically replenish the stock. And again, it's not by, to point fingers anywhere. It's because it is a very delicate process of making sure that these vaccines stay stable and stay in the correct cold chain, as we call it, in order to be used and used when we know that they're going to be efficacious. So the second dose can be up to 6 weeks, and we've seen that if you're going to be able to get it like at 4 weeks from Moderna, if you get it at 6 weeks, it's fine. If you're not getting it 3 weeks of Pfizer, you get it at 4 to 5 weeks, that's fine. But the window is really not earlier. So you don't want more than 4 days earlier than your designated time to get it.
Okay. Well, thank you. I want to be respectful of all our panelists' time and our participants. I appreciate everyone logging in tonight and all of your great questions. There's a lot of questions if we're recording tonight. We are recording tonight. We're also doing a shorter version of this on February 2nd. And so we'll probably be sharing this on our YouTube and our website about a week from today. Again, I know there's always questions about trying to get that vaccine. My own personal advice, what I did for my parents, midnight. But please look at the beginning of this chat, and that will give you the information on clicking on our Northwell websites. Check frequently. The minute we have supply, more appointments are released. So with that, I will say farewell. Thank you again, Dr. Fagan, Dr. Camp, and all of our participants tonight. Stay well, everyone. Have a great evening. Take care.
Good night, everyone.
Thank you.